Okay, well, thank you for joining us for Q&A again this week. Now, this is a little bit different because what we're going to do this time is have a chat to Erin, and I preluded to this last week when I gave you the videos of Dr. Jeanette McLean doing her stainless steel crowns after silver fluoride application. Now, I trained Erin in silver fluoride because she lives 10 minutes up the road, and we're study buddies for a while back there. I trained her on silver fluoride in the very early days of my exciting journey. And so she began implementing that, but she also has been trained in stainless steel crowns and has had experience in that as well. So for somebody who has actually been doing stainless steel crowns and silver fluoride for a long time in Australia, and I'm talking whole crown, not your traditional stainless steel. Is that right? Because I was trained in traditional stainless steel crowns, but it kind of flies in the face of doing anything with silver fluoride because we're talking minimal intervention. And your traditional stainless steel crown is definitely not minimal intervention. And so I invited Erin to come in and have a quick chat about her experience and what she's learned along the way. And a lot of the things that she has brought up is really quite different from what I thought we would be talking about, but it's very valid and relevant from a clinician's point of view to a clinician's point of view. And I just want to preface this by saying, look at us in Townsville today.
It was 8 degrees when I left home.
8 degrees. We're chilly.
It was actually colder than Newcastle.
Well, winter is on, and we're loving it. And I'd show you my 30-year-old Ugg boots, but not really as much to be seen on YouTube or whatever. So anyway, Erin, welcome to Q&A. Yeah. So tell me, can you just tell us what you've found, learned and experienced with
So
fluoride?
I work I'm an oral health therapist in private practice. I do about 50% kids, 50% adults, and out of those, I think it'd be out of the kids more than 50% CDBS Medicare patients to private patients. My clinic also has 2 separate locations. Our first location, where I used to primarily work, was in a lower socioeconomic area and surrounded by other lower socioeconomic areas. So I did a lot of CDBS and Medicare on kids. But I was trained in the whole crown technique, and then Kathy introduced me to silver fluoride, and I've been doing that a lot more in the last few years, but I don't often do stainless steel crowns anymore, I'd like to say.
That's not what she's here for. Okay.
No, that's not what I'm here for.
Clinical experience, okay.
I think stainless steel crowns, they have a very, they're part of your toolbox, and they can be a good a good tool in certain cases. But at university and things, they really do teach you that of gold standard, and I know that a lot of the grads are graduating now as whole crowns as gold standard, and gold standard treatment in pediatrics. And even when I went to the pediatric update, they showed us all the stats on the longevity of fillings versus stainless steel crowns, and obviously stainless steel crowns were winning. But what most people don't talk about in doing primarily CDBS, and this is my experience, I do a lot of CDBS on like low socioeconomic kids, is often these kids come from families that once that $1,000 is depleted, that's it. You're either in my clinic, we decide that if they go over that $1,000, we charge them CDBS fees privately, which is a lot cheaper than private fees, or we can send them back through the public system. But a lot of the parents don't like going elsewhere. Once they've found a clinician that they like, they want to stick with you. And once you try to get them to go elsewhere, you leave it up to them to follow through with the treatment. So with these kids, and I know I'm not the only one, you're stuck in a situation where you've really got to do quite complex treatment planning, I think, to look at what teeth are a priority in terms of needing to be saved, what teeth are going to fail first, as in becoming toothache first. And then you get these kids that, you know, that $1,000, that's three hall crowns, or three stainless steel crowns, and that's it. Most of the time these kids come in needing, you treatment plan it up, it's like $2,500 worth of Medicare fees, and they need 8 fillings or you know, multiple big work. So then you have to sit down and you have to go, okay, if I stainless steel these crowns, if you know, if the E's need, so the upper E's are heavily decayed, if I put stainless steel crowns on these, it then creates a lot higher incidence of having an ectopic 6 when the 6 erupts. So if you're doing it on, say, a 4-year-old, am I going to then create a bigger problem if it does go ectopic and then we end up losing the E's prematurely, which then creates a space loss issue? Is this family in a financial situation to then go down the ortho track, which often they're not? So would it be more beneficial to use something like a silver fluoride, a temporary filling, whatever, and monitor until the 6 is in place? So yeah, often with CDBS, you've really got to treatment plan well. And I just find that 3 stainless steel crowns just doesn't hack it on these kids. And then if you do that kind of treatment where, you know, do 3 hall crowns and you leave other treatment, or, you know, you give the parents out-of-pocket fees, sometimes they don't come back for treatment. So then you've got a patient that comes back in 12 months later with toothache. So then you're putting the child through an unnecessary extraction and that whole ordeal of getting a tooth out as well. It doesn't matter how much education you give some of the patients, you know, once that CDBS is depleted, that's it. So I often do now a lot of silver fluoride on their first visit, because with CDBS you do often have a higher rate of FTAs. So you can do your checkup, your treatment planning, your x-rays on the one visit, and then you can go, okay, I'm going to get you back in for fillings in 2 weeks time, and sometimes they don't show. So then you do get, you know, that toothache scenario down the track. So if you see them for their checkup, you can do their x-rays, you can go, I'm just going to do some silver fluoride on these teeth. You can stabilize them. And then for whatever reason, if they don't show up, if they don't attend treatment, I always say I can sleep easy knowing that those kids aren't going to be in toothache. And I actually had this in a patient 2 weeks ago, and this little girl came from a family of 6, and she was the youngest, and the mum wasn't really worried about her. She was more worried about the younger ones because she was only 4, and she came in and she had
the older ones.
Sorry, the older ones. And yeah, she came in, she had big cavities in her 6s, and I was running late, and I just said, oh, we'll get her back. And then I went, actually, no, I'm gonna I spoke to the mum about silver fluoride. I said, we're going to do this now, and then we are going to get you back in a few weeks time to fill them. She wasn't in pain yet, which was great. I did her silver fluoride. It only took me 10 minutes. Mum was happy. And then 2 weeks later, they failed to attend their filling appointment, and now we can't get a hold of them to try and bring them back. So I do know that is a regular thing with CDBS patients, unfortunately. And I will see them again, but often you see them again when they're in pain.
Yeah.
Which isn't ideal.
And Erin's speaking from a private practice point of view, and having worked in the public system, the fact that once the CDBS runs out, then you can convert over to public health funding does not necessarily mean that the kids are going to still turn up for treatment.
And that's the biggest thing.
And we've seen that, you know, time and time again. So what Erin is doing here is using silver fluoride as a stabilizer mitigator in case they don't come, but it also means that she can stage the treatment, and that's what I use. I use it for too. As you know, I'm not doing stainless steel crowns, but what I do is get the whole mouth cleaned up with the silver fluoride first, and then you can start working your way around, knowing that everything else is a status quo. Now, when you're combining silver fluoride and then deciding to put a stainless steel crown. When you were doing that, okay, the advantage of using silver fluoride first before a stainless steel crown, which I know you've explained to me. Tell the world now.
Rest easy. I know that all the research is, you know, if you select your case well, whole crown and covering the caries will stop everything from happening. But then you go to these PEDS conferences, and what is the statistics on, I think, you know, paedodontists extracting stainless steel crowns?
It's fairly high.
It's quite high. So I don't like, and I guess this is, you know, the way we were trained. We were always trained to remove the caries, even though they're, you know, they're teaching us it's okay to, you know, it's okay to cover it, it's okay to cover it. When you can put the stainless steel, when you put the silver fluoride on, I know once again I can rest easy knowing that it's arrested underneath there, and then you can bring them back in and pop the crown over the top, knowing that it's stable underneath.
Do you do that on? You don't do that same day though.
No. No.
Yeah.
So
I had a question a little I think last week about if you were going to do you know, silver fluoride and then a restoration straight up, which, you know, hopefully I answered online adequately for that practitioner and for everybody else. But the idea of being able to treat the caries, knowing then that when and getting the whole mouth done, then knowing that everything is asymptomatic, everything is arrested, and then if you choose to use a stainless steel crown to put that on top of you know, that tooth, you're still applying the GIC and you're doing that. There's two advantages that I can see in doing that. One, you know that you have treated that tooth and the caries, and you've started the remineralization process. So you are not actually sealing in any potentially anaerobic bacteria that is still going to have a heyday if you cover it with a stainless steel crown. It's the anaerobic ones that you have to really worry about in that instance, and that it's not like they're color coded. So to me, by knocking them all off and then putting your stainless steel crown on makes a lot of sense at a separate visit if you can.
Yeah, and I think
because it's less messy.
I think with a lot of the grads that they're promoting stainless steel crowns and Hall techniques with as well, is I think it's really providing a false sense of security, because when the OHTs or when the clinicians are going through uni, they often don't see the patients again.
True.
So they do your crown, they put it on, and they go, success. I've never had one fail, because they've never seen the patients again. Whereas when you're with, how do you know that it's not the paedodontist down the road, that all of your stainless steels are failing down the track and abscessing? You don't know. I have extracted quite a few abscess stainless steel crowns previously, not my own, but from someone else doing them, and you might have gained a year, and that's great. But with these kids, was it worth gaining a year and then
extracting the tooth anyway?
And they're usually ease, which aren't nice to take out. And yeah, I know I'd like to be sleep easy, knowing that the decay is arrested underneath before I put a crown on as well. And once you do a crown, you can't radiographically see underneath it either, so you can't see if something's going on. That's one benefit for fillings. You can see if something's happening underneath them, whereas stainless steel crowns, it's just pop, that's it, pray, you know. Pray that nothing's happening.
And you're not dismissing it as a treatment. You're now saying,
no.
From your experience, you've flipped now to using stainless steel crowns rarely, and using what are you using, a GIC?
Depends on the child, but I often use so I usually pick up the caries at their recall appointment, or at their initial dental hygiene appointment. At that appointment, I usually put silver fluoride on, particularly on the younger kids that you don't know how they're going to go with LA, if you need LA and things like that. I pop it on and then I bring them back in a few weeks' time. Once again, if they can't get in, because my books are quite busy, everyone's at my work's quite busy, if they can't get in for a month, you know that it's going to be okay. They come back in a month's time. You don't need to use LA. You know, you give the kids a great experience. You can use the slow speed. You can use everything. You don't need to spend that extra time in numbing the child up, and you don't need to spend that time in giving them that new experience of needing to numb them up either. And the tooth's not sensitive at all. You can do a really good job. You can do a really good filling.
She didn't believe it at the beginning.
I didn't. No, I didn't. I didn't. Kathy was telling me all this amazing stuff, going, I had this patient, and I was just like, nah. But I often am. Everyone's the same. You trained how you trained. And it wasn't until I would finish the filling that I went, oh yeah, I could have done that with silver fluoride. I could have done that with silver fluoride. Like, it wasn't the first thing on my mind. Whereas now it's the first thing on my mind because it's so amazing that we use it for everything. But it's quick and it's easy. And then you can bring them back and you don't need to numb them up. It stops you from extending the cavity deeper than what it needs to be too.
Oh, for sure.
Particularly in adults and in teenagers, where you've got a decay that's close to the pulp, and you look at it and you're like, oh, you know, I might expose the pulp. In those situations, you're not removing the decay. So you pop the silver fluoride on it and that stops it. So you are not going to hit that pulp because it's actually made the decay hard. Whereas if you were just removing the mush, then suddenly you're in the pulp. So yeah, it creates that and desensitizes everything beautifully. But I was telling Kathy before, I had an amazing case on a hypoplastic tooth last week, that I think I was more excited than the mother and the patient was. I was like, oh my God, this is amazing. Because this little girl, she'd been treated, she'd been traumatized. She'd been traumatized because someone had tried to numb her up and do a filling on this hypoplastic tooth that they couldn't numb up. So she felt everything, and she was very protective of the tooth, and she wouldn't let me anywhere near it. The filling had then fallen out, and then they were back with me wanting something done, and there was no way that I could even get in her mouth. But we tried silver fluoride, and I didn't do a great job with the silver fluoride, but I got it on there and I held it for a couple of minutes, and she came back a few weeks later and she said, I want it done on all of my teeth because I'm eating ice cream. And I was like, oh my gosh, that's amazing. We used the slow speed on her, and we've decided to do a second application just to make sure. And then we'll bring it back.
Because there was a little brown spot there.
There was a little bit. It wasn't soft decay, but it wasn't as hard as what it usually goes, is what silver fluoride usually goes. And because it's a permanent 6, I just wanted to, you know, really make sure before we do anything that it sounds. So we've done another application. We'll bring her back in 2 weeks. But I looked at this tooth going, this is so beautiful. I'll be able to do the most beautiful filling well. And that's another thing that silver fluoride does in those kids that, I don't want to say uncompliant, but, you know, these kids that you know that you're not going to be able to do an ideal job on. You know, you might be able to put a filling on, but how good is it going to be? You don't know. And even stainless steel crowns, you can do the same thing, and they're marketed as being really quick and easy, but on an uncompliant child, it won't seat well. And you often get one go. You know, you get one go of putting them on, and then if it doesn't seat well, you know, you've kind of lost their compliance, and then it'll fall off, and then you're back to square one.
And they're not without their trauma.
No,
because of you were sort of saying about the
I thought I was doing stainless steel crowns wrong, because I went to other clinicians and I said, I get tears about 50% of the time when I'm doing stainless steel crowns. And I think it's because the kids struggle with and it doesn't matter if you use topical or whatever, they struggle with that tightness. And you know, they don't just seat on, you do have to push them over the tooth. So, and a lot of the kids struggle with that. I had molar bands for ortho, which would be similar, and I cried when I got them on, because they go subgingival, and they do rip apart those periodontal ligaments a little bit, and that hurts. And I still remember that, getting them done when I had ortho, and I was a lot older than, I was 13, 14. I wasn't 4 and 5 like some of these kids getting stainless steel crowns are. And that also downed my confidence as well. When I'd get kids with silver fluoride, you give them such a good experience and such a positive experience, and you're able to build their trust so easily. And then with stainless steel crowns, I was often getting, and the clinicians that I've spoken to, I go, oh, do you get tears? And they go, oh, yeah, but it's only for about a few seconds, and then they get over it. And I'm like, yeah, but I never get tears. They're always so happy when, you can do silver fluoride and fillings. And I don't want tears. But
yeah, I mean, for the clinicians out there who are skilled and gifted at doing stainless steel crowns,
and I know there are.
Yeah,
I think
I think what I wanted to present was the fact that if you're using silver fluoride prior to a stainless steel crown, there are certain advantages for the bacteria, and particularly when you've got very, very deep lesions.
Yeah,
and if they're not very, very deep, then it's a big job to put them on, because we know how small we can create the lesions with a GIC. But we're not trying to say it's one against the other. We're just presenting. Well, I got Erin along to present from a clinician.
You can tell that I love silver fluoride, obviously.
Trained her well.
But I do still definitely think that there's a really there's a place for stainless steel crowns, but I just think you need to look at all. You need to look at all the options. And I had 2 kids in yesterday that had some stainless steel crowns done down south, and they were beautiful. They were both done under GA as well. They were both quite young. One of them was 2 and the other little girl was 4. And they had stainless steel crowns on their Ds.
Right.
And for them and for that situation on a 4-year-old and a 2-year-old, that would have been the best situation treatment under GA.
Yeah.
Because they're going to be there until they exfoliate naturally when they're 10 or 11. But on an 8-year-old, I probably just would have silver fluorided. Because you haven't got as long to wait as well.
True.
You've got to weigh up all the avenues, and also when you're working with CDBS and you're dealing with that money restriction or that financial restriction, is it nicer to do a silver fluoride and a filling, and to use that extra funds to build the relationship with the child and bring them back every 6 months? Or do you want to just treat them, get them out of pain, and then not see them until the funds renew in a few years' time? I'm very much about building relationships with my patients and parents, and building good habits. And that's what CDBS allows us to do as well, with these kids. It allows us to bring them in every 6 months and teach them what's important, and teach them to brush, and teach them to floss, and build that relationship. So when anything does go wrong, and I'm very lucky that a lot of my kids, they never have anything wrong, because, we've been able to educate them so well. When you do bring them back, they love seeing you. You're able to give them a good experience. But when you're in this issue that you fix them up and then you send them away, you might not see them again.
No, and the thing is, the whole idea of CDBS was to have the ongoing preventative care availability to the kids. There's one thing I want to just talk about. That hypermineralized case that you were just explaining had already been to the orthodontist, and the orthodontist said, keep the teeth.
Yes.
So that was very difficult if you didn't have.
So when I saw this little girl, she'd been, I couldn't get anywhere. I got a look in, but I couldn't get anywhere near her mouth with anything other than a mirror. And I instantly knew that these teeth weren't going to be there forever. They were severely hyperplastic on the occlusal surface, but the actual crown of the tooth was okay. But the decay was about 2/3 to the pulp. Of the 6s, there was 2 or 3 of them off the top of my head. I immediately sent them, took an OPGs, briefly explained to mum that if we, the orthodontist might want to remove these teeth to allow the 7s to migrate into the position, because this little girl's not heading towards ortho, which is good. But I sent her to the orthos, and I was actually quite surprised that the orthos wanted to keep them. and leave them there at this stage. She's under 12 monthly review.
Right.
So then I saw her again once the filling had fallen out. And I was stuck with how are we going to treat these teeth? Because I can't numb her up. And the orthos don't want to take them. So
well, the timing's probably not right for them.
Yeah. So they're reviewing them. But if we can stabilize them, these teeth are actually in the position that they might be okay to just do a nice onlay or something over the top when she's older. She's older. So yeah. But I was so ecstatic that she could eat ice cream, because before I couldn't even get in her mouth.
Yeah, so, and it's the winning.
It's definitely a massive win. I went around to all the dentists and told them, and they were kind of like, yeah, that's really good. And I was like, no, it's amazing.
Until you have it happen to yourself, you don't realise how excited you get.
No, especially with the enamel hyperplasias. Yeah. It's terrible, and it's one of those things that once you can't get a patient numb to restore, you kind of don't know what to do. I don't know if I can. I don't place stainless steel crowns on sixes. I don't think that's in my scope. I've never done it.
Well, they're not Hall technique was never designed for
sixes.
For sixes.
Yeah.
And I've got a case that I have unfortunately had to rescue where that was done, and the Hall crown was applied, I think, about 2 or 3 times because it kept coming off because it wasn't seated properly. And when we looked at the overhang, it was definitely going to cause ectopic eruption of the sevens. It
had quite
massive.
It was
so I had to get the crown off, and then the absolute mush that was underneath that crown is, anyone who does my full day course gets to see this in action. What they haven't seen is the whole story, which we've gotten to now. So Perth, you lovely folks in Perth will find that out if I can get over there in November.
It was quite heartbreaking as a clinician to see those photos.
I nearly cried.
I was in shock, and it was heartbreaking because they were permanent teeth. Someone had thought they'd done the right thing by putting a stainless steel crown on it, but it was poorly seated, and obviously the bacteria had just gotten underneath it, and this tooth was mush underneath.
And I've got the before photos. I've got the clinical photographs from before it was done, because it was seen at the practice that I work at, and then it went somewhere else. We'll talk about the tooth, the teeth were taken somewhere else, and this was the treatment that was provided, a great trauma to the child, so that I had to then deal with that. But anyway, look, it's a beautiful story, and I saw her the other day, and she's eating ice cream.
Yeah,
she's eating ice on that tooth.
We're talking about the decay, but from an ortho point of view, the bite was severely affected as well, because I think children's bites can adjust about 4 to 5 mil in primary dentition.
But in the primary dentition,
right? But these were permanent.
And
they were in the bite, and they jacked open her bite right up too.
So basically, she was left with a posterior open bite. She was biting on her sixes, and then just only had her anteriors. So for the 12 months that those teeth were covered by the crowns, had an incorrect occlusion, which from a myofunctional therapy point of view,
and then we've opened up that Pandora's box.
Was just shocking.
Lip incompetence and overactive muscles and all this kind of stuff.
And so as soon as they came off and she was biting, she goes, "Oh, that feels better already," and speaking and everything. And that's one of the things she's really happy about, is she can eat properly. Anyway, look, a different story. Please don't try and put a whole crown on a 6-year-old molar where you're having trouble. And
I know the way I see it privately isn't how it's often handled in public clinics. I know this is only my experience, but I just know that I sleep easy at night, easily and atraumatically, popping some silver fluoride on the tooth and then bringing them back, whether at that stage you choose to put a Hall crown on it, or whether you choose to restore it, looking at everything involved, whether it be, you know, the CDBS balance, or whether it be the
actual
stage of
turning up for the
eruption,
appointment,
or the FTA rate or anything like that. But from a dental business point of view too, after school appointments are quite high in demand. FTA rates for CDBS are quite high. So I know we call it killing the bear in the chair. At my work, we call it killing the bear in the chair. If you can kill the bear in the chair, treat the decay at that one appointment, and at least arrest the decay, there's no reason that, well, Kathy, you could say that I often try to bring them back in a few weeks' time. But if you're really sure, there's no reason that you can bring them back the next recall.
Well, or at least next school holidays.
Yeah, or next school holidays.
You know, we're regional, and a lot of our patients travel to us, and so if it's next school holidays, then that's
and that
it.
way
But you're not losing ground,
and you're not telling the parent, I need to see you again in 2 weeks, and I only got an appointment in the middle of the day, so you're going to need to take them from school, or you're going to need to, you know. And we've got a lot of working parents, so it's a lot more convenient on parents as well.
Yeah,
when you can kind of work it in more
with them,
around them,
yeah,
as well.
They might have an RDO once a month or something.
Exactly. And when you start to, I know there's a sigh of relief when I say, listen, we've got a bit of time. I say about 2 weeks, and then the parents go, oh, we're going away in 2 weeks. Can we leave it a month? Yeah, that's okay. Sure. We'll do it in a month. And they always come back. And I've never had a negative silver fluoride experience, which I think as a clinician builds you up as well. And I know there are some clinicians out there that have excellent experience with Hall crowns, and they do them very, very successfully. I just know, for me, when we look at all avenues, I love silver fluoride, and whether you put a stainless steel crown on it afterwards, or whether you restore it, it works well. But silver fluoride is amazing whether you crown it or not.
If there's another spokesman for silver fluoride, it must be Erin. So,
yeah.
The other thing too we've got to talk about is that for those of you who are using CDBS does not pay on a silver fluoride application. So because the dollar value of actually providing that service is minimal as far as cost goes for the treatment, what do you do? Do you just charge just that you can get them all done in the one fluoride?
This is a conversation that people need to have with their obvious principal dentist or their boss. I know at my clinic we're more worried about time and appointments, because we are, I think my next, because I'm at uni as well, but my next available appointment is, I think, the middle of September for me. So our biggest thing is, like I said, kill the bear in the chair, and if we don't need to have more appointments than what we need, that's the most important thing for us. So if I've already got them in for a recall appointment, we're charging that, we're going through with that. I often don't charge for a CDBS for a CSDS, silver fluoride application, if I'm already doing other stuff. If I'm already doing fissure sealants or whatever, I just do it. But if we do it, it's a lot easier. I guess I hate using the word selling in dentistry, but selling the parents, it depends on what you charge as well. Whether, I think CDBS prices for a 1-2-1 is about $27, whether you say $30 per application. I've never had a parent go, oh no, I can't afford that. You know, if you say $30 per application or whatever at that one appointment, they're very receptive to that, because it's a lot cheaper and more affordable for the parent, and also they don't have to come back and things like that. So but often I often don't charge for it, because as a product it's very cheap. It's like, what is it, $1 an application, or
no, it's about 40 cents.
40 cents an application.
40 cents an application. 40 cents a drop, I think. And so you know by the time you get a few teeth done out of that one drop. The other thing too is, if you're looking at productivity, which a lot of people, need to. What the amount of extra time you might spend in doing that application and either not recouping very much money or just charging a 121, because you can do it under a 121 if you're using CDBS funds and they don't pay.
We do it.
But you will be able to get 3 fillings done in the next visit.
Exactly.
For the small amount of time. So that, because of the fact that you don't have to give LA, and so your productivity ultimately increases.
And this is the way we're kind of taught at my work. Like every minute kind of counts. So if you can sacrifice your, and do that silver fluoride at that appointment and not bring them back for the application, so to speak, you are able to make that filling appointment a lot more productive and do, say, 3 fillings in 40 minutes or whatever you need to do, because you don't need to and go through all the explaining and the show and tell. Well, not that you show the LA, but the feelings, the feelings and everything that go with it. The feelings and everything that go with prepping the child for this new experience of being numb. You don't need to do any of that. It's just showing them the bumpy slow speed and just doing a little filling, and it's a lot quicker, a lot more productive. I know for me that's time poor as well.
And with the good GICs, as you know, I like Equia Fort, and that's just because of the many factors that it's high viscosity, so it's really easy to work with. It sets very quickly. It's a high fluoride content. The content is very high, akin to your Fuji 7s. So it's perfect for, and it's got great contouring. You can actually trim it and everything within the 3 minutes. It's beautiful to work with, but it's very high strength because it's self-curing, but it's got a little tiny bit of resin in there, and that makes it extremely long wearing and wear resistant, and it tends not to fracture as much around the edges. Particularly brilliant for use in hypermineralized teeth.
And I know Kathy talks about it in her courses and things, but I just want to hum on about educating the patients on black diamonds and what they look like. And I always tell, because Kathy was using this before, like obviously before me, but I didn't know about it the first time I saw a black diamond. And I told Kathy this, and when she started telling me about it, I was like, oh, because I saw a patient and they'd obviously seen, whether they'd seen you or whether they'd seen someone else, and they had this look like a black cavity. In that, now that I know what I'm looking at, you can see the difference between black caries and silver fluoride once you know. But if you don't know and haven't used it, the first time this child opens their mouth to another clinician, it looks like you've got a hole. And then it wasn't until that I told the patient, you need to fill in. It wasn't until I actually put a burr on the tooth that I realized it was very hard. Very, very, very hard. And then I actually stopped what I was doing. I went, is this tooth being silver fluoride? And the mother kind of looked at me like, and then I said black diamonds. She goes, oh yes, that does ring a bell. Blah blah
Must
blah.
Have been one of mine.
That does ring a bell. Oh, I know what you're talking about now. And the only reason, and I always say to my parents when I do it, so for whatever reason, if they move, if they go to another clinician, if they do whatever, if you somehow you lose the teeth. As in you lose the patient and they see someone else for whatever reason, I always show the parents what they look like. I show the parents the black diamonds on our photos, and I say, make sure you tell the next clinician if they see anyone else that this tooth has been treated with silver fluoride. And I tell them honestly, because to someone that doesn't use this or isn't familiar with using it, it may look like decay, but it'll be hard. And I really reiterate that, and I tell them, because the first time I saw it, even though I'd heard about it, I thought it was decayed. And I say this because it has happened. I've heard stories about kids going to other clinicians with silver fluoride and the parents getting in trouble for all these cavities in their mouth, but they weren't cavities. They were hard silver fluoride teeth that just hadn't had the fillings popped in yet. So, and also underneath.
Do you give them the cards?
Yes,
the
I do give them
cards.
a card, but yeah, I really reiterate, it's hard, it's hard, it's hard. It's black.
She's like my standard. Next time I'm, too sick to give a course or something, I'll just get Erin over it because, I've trained her really well. But it's good to see other clinicians who have independently started using a product, to change their world as well.
And during COVID.
Oh, it was great.
During COVID, I was getting called in to treat the children in toothache, and you weren't supposed to be using hand pieces or anything during that time. So silver fluoride was our go-to.
Yeah.
And I was actually teaching the dentists at work how to silver fluoride these adult patients because there was no aerosols created. You could use, if you weren't allowed to use a triplex, you could use a cotton pellet and just a cotton roll to dry the tooth, paint the silver fluoride on, and then you can deal with it post-COVID. So Victorians, especially at the moment with what they're going through, silver fluoride is amazing to have in your toolbox because. And it's quick, it's easy, which means less exposure to the clinician as well if we are talking about COVID situations. And there's no hand pieces or anything involved, which is great.
I think what we might play with is having a session one day where people can join in and talk about if the first time they used silver fluoride was during this, where they were forced to during COVID, and then when the patients come back and their experiences of what they've discovered and learned by
but there was no greater feeling than having a little girl that wouldn't let me in her mouth and couldn't have anything cold at all to come back and say, I wish, I want it on all of my teeth because I'm eating ice cream.
Yeah.
That was amazing. But now we can treat her as well, which was good. Yeah. So it was a great experience.
And I've had the same thing. And I get, and now I can eat, hot and cold things on my back teeth, which is what you're supposed to be eating them on. But with the hypermineralized kids, you can't. So
and these kids that you go, I don't know how I'm going to numb them. You go, oh, I've got to numb this little kid. I've got to numb him up. You put silver fluoride on it and you bring them back. You don't need to numb them. You don't need to numb them. It desensitizes everything.
It's good stuff.
Right.
She's a convert,
biased.
but anyway,
I'm pretty biased. But I think stainless steel crowns are great to have in your toolbox. But you just need to look at all avenues as well.
And for people who are new graduates or old graduates, I guess, I think one of the greatest things is that we always should keep learning. And that's one of the reasons why I've continued with this Q&A exchange, even though it's sort of me doing a fair bit of the organising and the talking, because I suppose that's what you do when you start a project. But it is, the fact that other clinicians are expanding their minds and learning things and trying new things, and is one of the most valuable things, because this is all about the patient in the end, and retaining teeth and making dentistry pleasant and giving people a pleasant experience so they can actually, they're not afraid to take their kids to the dentist. A lot of kids are not very regular attendance because the parents don't want to come, because the parents have got fears and things like that. So by bringing them together in this way, and when it's fairly, can be cost effective, I think we're winning for the future, hopefully.
Silver fluoride's very exciting. It's now at the top of my mind instead of the bottom of my mind in any situation. Kathy mainly sees kids, but I've been even using it on DBA patients DBA patients as well. Those distal root caries on the backs of 7s and the backs of 8s, and you just can't clean them, and you can't get to them with a burr. Just to stabilize them is amazing, and from the sensitivity point of view too. So it's such an exciting product to have for kids, but also in terms of the elderly and nursing homes, and
But even
that
not
kind of
that,
stuff.
even about, like I was explaining to Erin, I've got a patient and one of my hygiene patients, I'm actually managing to hold on to one of her, or a couple of her teeth, because she's not ready to have them extracted yet, and she's going through medical things. But I'm using it to mitigate the progress of all of the things that were giving her problems before, until the time is right. So we're mitigating sensitivity, we're mitigating subgingival caries, we're mitigating her inability to be able to clean around that area, because I've put silver fluoride on there, so there's no plaque sticking around the gingival, we're in the root surface where that has been exposed, and it's a tilted 1-7. But the other thing that we're discovering, which I haven't ever talked about yet, except to people who listen, is we're actually mitigating the periodontal disease. Now, that's a whole other can of wonderful worms. But by doing all those other things, I'm finding that her perio is not there anymore.
Yeah, you're going, oh,
yeah,
what's happening here?
And
the perio is getting better
the
as
perio
well.
is getting better, and being an antibacterial.
Is that just, the antibacterial, the silver, maybe?
Antibacterial, yeah. And so that's interesting, and I'll keep you informed about that one, because I'm looking forward to doing a little bit more.
It's almost like your solution to everything now, isn't it? Or I know it's almost my solution to everything. Silver fluoride, silver fluoride.
Well,
silver fluoride.
I mean, it's not the be all and all, but it's getting close.
It's very.
The more you use it, the more you use it. It's one of those things. Anyway, Erin, we better end here, because we're just talking about our favourite subject.
Yeah.
And Erin has to hit the road and get back up to Cairns this afternoon. So thank you so much
you're welcome.
for sitting out the back and having a yak.
I know everyone
morning.
can always see how passionate we are about what we do, but honestly, once you start using it, it's very amazing stuff. So
anyway, hopefully you've learned something, and if you have any comments about anything, leave them. If you're watching this through the Silver Fluoride Practitioners Q&A exchange on Facebook, if you're watching it through that, hop on and leave a comment on there. Otherwise, if you're finding this on YouTube, because it gets posted on YouTube, then if you've got any questions, you can shoot me an email at kathy@armer.com.au, and we'll attempt to answer them there. Okay, thank you so much, and enjoy the rest of your day. Okay, thanks, Erin.
Thank you.